My role is to talk to patients, whether they are on chemo, radiotherapy, immunotherapy, tell them about some of the benefits around exercise and so much of the emerging evidence, and then really help persuade them as to why strength training is key as part of that journey. What we are seeing with some of the evidence coming out is the impact that certain types of exercise, and that is predominantly strength training, how it changes or impacts our physiology. We believe it helps oxygenate the tissues. That's going to improve the efficacy or the success of the treatment. People who'd had a regular exercise regime do better during treatment, from diagnosis stage to pre-op stage to post-op to during and post-treatment. It is only going to benefit them. The patients are then their own advocates. I should have taken a picture of the wall at the clinic, because the thank you cards of people who just say, you have changed my life. I have the best job, because when patients feel that sense of achievement, it is such a lovely thing to see.
Welcome back to the Never Told to Live podcast. And today I am joined by Sarah Marsh, who is going to talk to us today a little bit about strength training and exercise in oncology and cancer patients. So I'll let you start, Sarah, with a little bit about your background, how it is you've come to help oncology patients, and we'll go then a bit more into the benefits of strength training and why it's so important.
Brilliant. Thank you, Chris. Yes, then thank you for the opportunity. So, yes, I've worked in exercise oncology for the last 5 and a bit years. So my role is, I'm lucky in one of the places I work to have our own gym. So we offer patients a 12-week exercise program, but my role is to talk to patients, whether they are on chemo, radiotherapy, immunotherapy, tell them about some of the benefits around exercise and so much of the emerging evidence, and then really help persuade them as to why strength training is key as part of that journey. So I've been a physio for about 18 years because I retrained, but yeah, I've been doing this for 5 years, and it is such a fulfilling job when you really get to see people and how much confidence they gain and control they gain back over their lives. Because I think anyone with a cancer diagnosis, for a moment, everything is done to you. All of the treatment is done to you, and it can feel like they're quite a passenger. So our aim is to give them that control and expertise of their own bodies back.
And in the email you sent me, you refer to it as exercise medicine for oncology, which then incorporates strength training within it. Just wanted to clarify really what exercise medicine means. Is it just encompassing all exercise, or does it kind of pick out a few specific areas within that?
That's a really interesting point, because I think at one level it is absolutely all exercise. But what we are seeing with some of the evidence coming out is the impact that certain types of exercise, and that is predominantly strength training, which has to be relative to the person in front of you, of course, and sometimes HIIT training, but with a cancer diagnosis that also can be quite hard to do. But how it changes or impacts our physiology. So it increases the number of myokines, which is a protein, and that actually can have a pushback on the cancer cells and reduce some of the cancer cell growth. Now, there's a huge amount of research being done in exercise oncology, and to the extent that we now have our own sort of setup, and there's a lot more conferences going on. And I think that probably 5-10 years, we'll almost be able to tell which dosage we have to give for which tumor group, which is amazing, isn't it? I mean, it is so exciting. So it's exercise medicine from that perspective, because we are giving it either before or during, and it can be, of course, it's not more important than the chemo, the radio, etc. But it is so important in terms of impacting the patient's well-being and strength and fatigue as they go through. So that's where that comes from.
And you've kind of started going into the next question I had, was about actually why exercise and incorporating strength training into that is beneficial. And you've mentioned the myokines there. You had another list of things within the email that you sort of specifically kind of relate more to oncology than it might be relevant in anyone else. Can you kind of explain some of the other reasons why it is so important?
Yes, so we believe it helps oxygenate the tissues. So what we want, that's going to improve the efficacy or the success of the treatment. So this can be, and we can talk a little bit about this later in terms of what does that actually mean for each individual. But by increasing the oxygenation of the tissues, so things like radiotherapy and chemotherapy should have more efficacy. It can help manage side effects. That said, it's also the side effects are a barrier. So we have to find the way through that for the individual in front of us. So it's going to reduce some side effects. It seems to improve longevity, reduce the risk of recurrence. And that's before you get to all of the things like, quality of life. But cancer related fatigue is a huge thing, particularly with chemo patients. So it can feel, I think, for patients quite counterintuitive to me be going, come on, we want to get you to exercise. So we have to work out what that level of movement is on that day, but with a little bit of time and consistency. And it could be marching on the spot for a minute, right? It doesn't have to be a lot, but what we see is it does help them manage their cancer related fatigue.
I think you pulled out a stat that it was a certain percentage of people who receive their diagnosis of cancer then immediately stop any existing exercise they used to do.
It's huge. So, I mean, it's probably of the patient population that I see, 85, 90%. So I will ask a question.
Oh
We
wow!
ask on a form. I know it's huge, right? But there's lots of reasons for that. And so people come in and I'll have asked them, they'll have completed on their sort of health questionnaire a little bit about what exercise do you do? And quite often they'll say, oh, well, I still walk. And I'll say, which is fabulous. Walking is a brilliant exercise. But they'll say, but I've stopped doing yoga, I've stopped doing any classes, I've stopped going to the gym. And my consultant says I can never lift again. And I'm saying, what, anything? Like, are you getting the washing out of the washing machine when it's wet? How much do we think that way? So basically, I feel that, and it's because it's a huge thing. So people don't know what to do. And so, in an abundance of care and a huge shock to their system that you have cancer, I think most people is like, okay, I'm just going to wait. I've got to go through the process, the diagnosis, the scans, the treatment plan, and then we start to talk to them. So I think it's a very natural response, but quite often, I mean, I have had maybe 3 or 4 people in the last 6 months when I say, what are you doing at the moment? And they just go, And I go, well, what do you do normally? They go, oh, well, yes, prior to diagnosis, I did this, but since, and it's maybe 3 or 4 people who go, well, I've carried on with this, and this. And things like, swimming, for example, is for quite a large part of their treatment is not a brilliant exercise unless you're lucky enough to have your own pool without chlorine in your backyard, because there's lots of infection risk. So I think that's the other reason people become concerned about their immunostatus. So they don't necessarily want to go to a commercial gym still.
Yeah, because I was going to ask then, do you think it is the kind of the shock and the overwhelm that actually puts people off doing the exercise, or is it this fatigue and all the side effects that is the thing that stops them? Is it, or just is it a combination of the two?
Yeah, I think it's a combination of the two. I think initially it's the shock and the I don't want to do anything. And I don't think it's really that long ago, let's say 10, 15 years, when people thought that moving too much might spread the cancer, right? So it's kind of okay, I'm not going to do anything that might make things worse. I don't want to change the cancer. I don't want to spread anything. So I think that's their first thought that, okay, I'm just going to, and it's also a position of overwhelm that they've got so much information being thrown at them. And then I think when they start treatment, then it's God, I am so tired. They said I might be tired, but now I really am fatigued. But it's not kind of exercise muscle fatigue. If they've ever done that, it's a different type of fatigue, but it's still quite debilitating.
And just to reassure people, then can you confirm that then is a myth, and moving is fine, not going to increase the rate of spread?
No, I know, but I understand why, and I think certainly if I said that to my mum, she'd be like, "Oh, well." So I think there's a generational aspect, and we are changing the narrative around cancer, in that we are able to manage and successfully put into remission so many cancers. So the oxygenation of the tissues is almost the antithesis of not moving, right? We want to move the oxygen around our bodies, and the reason for that is that the treatment is challenging, and the body has to manage and deal with the toxicity of the treatment. So we want people to be moving, but all of the evidence talks about you can carry on, subject to perhaps post-operative status. That's obviously an indication within that, and subject to how people are feeling. But relative movement is absolutely not going to cause them any problems. And from diagnosis stage to pre-op stage to post-op to during and post-treatment, it is only going to benefit them, because there's also all of the other pathology that we have, other metabolic conditions, that if we stop moving, it's unhelpful to us from a healthy life in general as well, isn't it?
Yeah, definitely. And it just reminded me of when I first qualified, and narratives around massage and cancer, and I know there's a lot of fears around that, is if someone wants to do something nice for themselves, they're having a rough time, they want to go for a massage because it is something that feels good. Is that still the case, that the massage is thought to increase the spread, or is it similar to the exercise where actually that's a bit of a myth?
I'm going to say it's a myth. However, I would consider where you were having your massage based upon where your cancer diagnosis is. So, for example, the easiest one with that is going to be breast cancer. If you're having radiotherapy, we don't want to be touching the skin at that point. So we would also be quite mindful of anything at the front of the body. If the person is really tight in sort of neck and shoulders, that might be, we would be safe there. I think, why would you not, for the time they're having treatment, look at that from an abundance of care and an abundance of caution? I mean, that to me would be sensible. But if that person really enjoys and perhaps has a bit of a stiff back from lying on the radiotherapy bed, or their hamstrings and quads are tight, I would say go and have a massage on that. Absolutely. It's brilliant to help, just to help you feel better. We offer, one of the clinics I work at, we're very fortunate, and we offer reflexology and acupuncture, which is very well evidenced to help obviously calm down the nervous system, and that is absolutely safe to have.
Just as you've been talking, I just wanted to get a bit more of an idea of what stage is it that people come in to see you majority of the time? Is it once they've had some more treatment and they're now kind of a bit more under control and they've got a bit more clarity of what's going on, or are they seeing you kind of right from the diagnosis point?
Sadly not. Well, sadly, they see us just after diagnosis, I would guess. So in my own clinic, I might get somebody who's been diagnosed and is yet to have treatment. So I would see them at that stage. So we would call that prehab. And this, I guess, is the next big area of where we can put exercise medicine and appropriate exercise in for patients. In the clinic I work at, predominantly, we will see people when they've been diagnosed and when they've had if they're having an operation, when they've had their operation. But we might see them at the very beginning of chemo. So they're coming in for their scans prior to starting chemo. So it will be during active treatment.
And because for me, it was trying to get an idea of like when you see someone in terms of that shock and overwhelm, and a lot of the time then they've got over that side, but it's the next bit. In terms of someone actually in active treatment of radiotherapy and chemotherapy, is there, other than the side effects that clearly you'd have to manage, is there any sort of things we have to avoid at that point, or is it do what you feel up to doing in terms of the exercise?
It's a little bit do what you feel up to doing, and depending on whether they're still feeling. So some patients, particularly with chemo, and especially if it's head and neck cancer, for example, or anywhere around the stomach, they won't feel like eating as much. So we've got a nutritional component to consider. I don't want somebody to be coming in and me exercising them and they haven't eaten. We need to manage the nutritional status and the hydration status. Naturally, on a chemo cycle, if they're having systemic chemo, you will have it, say if you have it on a Monday, then Tuesday might be okay, but Wednesday, Thursday, Friday might not. So we will try and match how they feel during their chemo cycle, and say on the days that you're feeling rough, just do what you feel like doing. And if that's a walk, that is fantastic. So that's how we would encourage it from that perspective. There's certain things like swimming is usually frowned upon during active treatment, one from an immunotherapy, or from how your immune system is going to cope. And from a radiotherapy perspective, because of changes to tissue, that we don't want people in a pool that is used by other people, and sometimes the chlorine can be, so that can be a challenge if patients love swimming. I mean, what I want people to do is the exercise they really like doing, because that's so much easier to stick with. But that's usually where we have to sort of say, you just need to pause that, not forever, just for a period of time.
is there any similar type of precautions in terms of the immunotherapy side of things in going to, say, a class type setting of yoga or Pilates where there's that chance of spread with other people and you encourage it more at home on their own?
Yeah, I think that, and that is, I think that seems to be quite individual. So we're starting to see a lot more, or certainly treat a lot more from an immunotherapy perspective, and having some really great results of that. So in terms of how the patient is on that from their own immune status, that's going to depend a little bit on what they had prior to their immunotherapy, because they're likely to have had some previous treatment. And then I guess it depends what happens in their home life. So we will have people who've got certainly school age children. So their school age children are going to school, and we all know how many bugs you pick up when your kids are at school, right? So I can absolutely understand that, I'd probably, if I wanted to go to the gym, I'd be going at quite a quiet time so I could be aware of my surroundings and not sort of the 5 o'clock everyone's piling in and queuing for whatever machine you're on. So I think they can manage that. So it's a little bit down to personal choice. We would suggest that they are mindful. I'll find a lot of patients don't want to get on a tube then, or a bus, for example. So they want to be a bit careful with public transport. And that seems to make sense because, again, it won't be forever. It's about managing that.
Because we talked a little bit about the class community feel before we start recording, and I'd love you to say a little bit about that, because it's a common theme I've had of people have come on the podcast who run classes, and just how powerful it can be to have other people in a similar, going through similar experiences to you and having the same kind of fears and challenges and barriers at the same time, to have access to those to talk to.
I think so. And just to even be in a room with them, isn't it? Some people are more talkers than others, I find. So in the clinic I work at mainly, we can have 5 or 6 people in the gym at any one time. They will have their own program, but they will go around and they'll have some similarities. As you know, there's only a certain amount of movements, key movements that we need to be doing. But it will be their own weight, their own intensity. And then we have other colleagues who run classes either face-to-face or online. And that is what pulls people together. People enjoy coming, and whether they decide to talk or not, or share or not, it just feels like a safe space. Because I think I said to you earlier, I said, it's not that we're in the same boat. Our boat may or may not have an outboard motor, I don't know, but they are in the same sea. And whilst everybody's experience is different, there's obviously so much understanding of each other's experience. And I just think that is so, so powerful. And that is one of the huge benefits now, post COVID, because pre or during COVID, this was really, really hard. But now we are post COVID and they can actually talk to each other. And you see them come into the gym, then they go and have a coffee downstairs together. And that's really, really powerful as part of healing and moving forward, I think.
Yeah. And I think, I don't know, I liken it back to even when my son was tiny and the NCT group, and having a group that you could text in the middle of the night, not it's more for his mum, but it's, having that people in the same boat, like we say, well, not necessarily same boat, but same sea, maybe going through slightly different experiences, could be really valuable.
Yeah, it is.
And so you've got mentioned the gym setting there and the 12-week program that you do. I'm curious to kind of hear how you then approach programming, and is it any different, or any specific considerations that you take, and are the goals the same in terms of that strength training program over those 12 weeks for someone who has cancer, or managing that?
Yeah, I think and obviously it depends where their start point is. If it's somebody who's been going to the gym before, we're in a slightly different position. The reason the program is 12 weeks is what we want to do is help. I mean, that's long enough, if not necessarily to see huge physiological change in muscle mass, for example, but to feel stronger. It's long enough to feel stronger. It's also long enough to start to create a new habit or recreate that habit. I can find that quite often patients aren't quite sure what their goals are. It might be, I want to get back to, and I'm going to use this as a method of doing that. And then I try and give them a couple of weeks, 2 or 3 weeks, and then I ask them to reset their goals, or just to revisit their goals, so that we can really meet them where they are. We'll give, we're going to look at a little bit of a warm up, but then we are going to look at some strength training. So your key movements, your leg press, your leg extension, your chest press, your your row. Now, so where you talk about consideration, so my breast cancer patients, I'm not going to be doing anything much here to start with, other than range of movement. And from an operational status, so I'm going to try and do a little bit of testing to work out. I want to give them a safe program, but I want it to be effective. So we work using the rate of perceived exertion. So how does it feel to them? 1 being nothing and 10 being what is going on here. And we want them to be, after they've done 2 or 3 sets, to feel that's like 5 or 6. So it's hard, getting quite difficult. And the reason we use that is to give them some control back and to remind them that they are the only, I can write a safe program, but they're the only expert of their body. And on different days, they're going to feel different. So that helps us manage the cancer-related fatigue. So if they come in and they are feeling exhausted, then maybe we don't do as many weights. Maybe we drop the weights down in order to get, because they're getting to 5 just by doing 1 set. The next week they come in, they're feeling more energetic. They might be able to bash out 3 sets. So that is how we approach it from there. And from a weights perspective, I really believe that I want them to feel successful. I want them to come in, do a program, and go, I did that. So I'm going to err on the side of caution, because I think physios are quite risk adverse, because we're very looking, and that we should be, we're looking for safety, but I want them to feel successful as well. So how post-operative they are, if they've had they've had some surgery, so wide local excision, or they've had their sentinel nodes biopsied, I'm not going to push them hard with the chest press. I'm just going to keep it nice. But I do want them to make that movement, because I feel that functionally at home they're doing that movement. Whether they call it a chest press or not, they're getting something. They're getting a can of tomatoes out off the top shelf. They're getting the washing out of the washing machine and hanging it up. So we want to support all of that. So I'm not programming to push too much, not to start with, and then depending on how they do, how they feel, what they say they want, then we can push. But to begin with, in my first 3 or 4 weeks, I want them to be successful.
So it's not building muscle for muscle's sake, or for the aesthetics of it, or just for the physiological benefits. It's bearing that in mind, but it's mainly, how can I make your life easier at home and make it look like the things you already do?
Yeah, because they will get stronger, right? They will so get stronger during that whole process. But it absolutely is. And I'll have a lot of women say, I want to lose weight, and they've been on chemo and steroids, and it's been so difficult for them. And I'll say, but I really believe the body can only manage so many things at one time. So now is not the time, but let's get you into a good habit around strength training, and that will hold you in good stead as you go through the other side of that.
So let's come on to breast cancer, and there's a few specific things we've talked about there. But let's firstly, just while we're talking about considerations around surgery, you mentioned there's still a couple of there's still consultants out there, or surgeons, who give messages about how much we should lift afterwards. And again, if some of those weights, they say maybe 1 or 2 kilos and don't ever consider anything much more than that, is that a myth, or is that something we can explore and push?
So I think that comes from their position of care. If it's the consultant, I have one consultant who writes in all of his consultant letters, you need an exercise program, which is absolutely phenomenal. And then a couple of others who, and I think possibly it's down to their own experience of exercise as well, will say, no, well, you can't lift, you have to be really careful. And I think there's enough fear in life already for these people. But of course, I might very well start with a 1 kilogram chest press or a 2 kilogram dumbbell. My aim is not, you're not coming to our exercise program to be beasted. You're coming to grow and develop and gain strength and confidence. So we start where they are, and I will start within those guidelines, but we will talk about how over time we need to think about progressive overload stronger. And after hopefully 3 or 4 weeks of 2 kilograms, it does become quite easy, and they can then start to progress and increase what they're doing a little bit. So, but it's obviously quite hard when a consultant says that. So I will try and personally, I'll try and get in touch with the consultant, but usually when they see other patients doing a little bit more, that's also helped. Then they might talk about what cancer did you have, how long ago. Oh, I can lift a little bit more then. So that's how we go with that. But my aim isn't to have them, walking out with a 10K chest press. That's absolutely not my aim. It's to help them understand the principles of strength training, particularly when, one of the side effects of breast cancer, less breast, but the medication post breast cancer, and whether we're talking tamoxifen or anastrozole, is that they're put back into menopause, or they have menopause symptoms, and they are at an increased risk of osteoporosis. So whilst they might be on drug medication for that, strength training is a free thing to do to help support that. So that's why it's so important.
What do you mean by they're put back into menopause, or what's the reasoning for that?
So if their tumor was estrogen positive, we will want to get rid of estrogen from their body. Most women, if they were on HRT, will be asked to stop HRT. So again, if they've been using that very happily and very successfully, then whether they are perimenopause or postmenopause, that's going to potentially bring back some of those side effects. And some of the side effects of the drug therapy is joint pain, hot flushes, impact of sleep. So all of that comes back again. So either they're put into medical menopause or their symptoms come back. So all of these just feed into those barriers of, I just don't want to exercise because I wake up feeling 100 years older in the morning. So that can be quite a challenge for these people. And it's hard, there'll be days when it feels easier than others, but our role is to help them through that and to help see and titrate the amount of movement that gets the joints moving, gets the synovial fluid moving, and helps them feel a little bit better, but isn't overdoing it. And trying to sort of perhaps understand that, muscle, not muscle strain, but, muscle, a little bit of, I've worked that muscle is different to joint pain.
And yeah, that must be really tough because, as you know, we had Michelle Lyons on the podcast, and we, in that episode, discussed all the different barriers and challenges that menopause alone brings. And if you're saying that having got over those, they're all going to come back and then effectively double the effect, because the treatment is also going to create the same fatigue and joint pain and flushes, etc. That's a lot to try and start something new, particularly if strength training has never been something that's been on the radar before or any confidence with it. So yeah, it must be a huge challenge.
So absolutely, it's huge, isn't it? Huge. It is huge. And not everybody gets all of the side effects, but I think we're very good in our medical healthcare of actually telling people about the side effects. But it's a bit like if you read the patient information leaflet on paracetamol, you might never take it. And of course, not everybody, but we have to tell people what may happen. So hopefully they won't get all of the side effects, but it's trying to find that balance. We want to educate people and empower them to make their decisions, but then we need to help them with how they might be feeling because of it. And I know I listened to Michelle's podcast. She was brilliant. And, that's a challenge, right? It's hard enough without your cancer diagnosis, trying to navigate space and time and energy to exercise without adding in sort of the extra complications.
Because another cancer, or specific cancer that you mentioned before we start recording, was prostate cancer, and then some of the symptoms that come along with that, and particularly in males that aren't having these discussions. Again, that's a huge barrier, and it'd be great if you could say a little bit more to that.
Of course. So I think in some ways they might feel they're starting off easier than the women. We don't have, so some men will have hormone deprivation therapy, androgen deprivation therapy, but not all. It's, I would say, probably 20-25%. So if the gentlemen are having that therapy, they will be having some of those hot flushes. They'll be feeling a few changes in their muscles. They might be developing what they always call as man boobs. So that can be really challenging in terms of how they feel about themselves. As treatment has progressed, we see a lot of patients who haven't necessarily had a prostatectomy, so they still have their prostate, but they will then go on to have 5 or 6 weeks of radiotherapy. So that's a lot, Monday to Friday, 35, 37 sessions. And what that is doing, in order to have their radiotherapy, because of where the prostate is, we ask for patients to have a full bladder and an empty bowel. And that's not an exact science, right? That's not an exact science. So we can work a lot with them. And our radiotherapists are brilliant in terms of how much hydration you need to have a full bladder. And the empty bowel can be a little bit more challenging depending on, we're all different about our bowel habits. And then being on treatment makes everyone a little bit tense. So it can really impact bladder and bowel habits. And because we're asking them to fill their bladder from a neuromuscular perspective, we are messing with their urge to urinate and their need to go more frequently. And you will see during radiotherapy that they usually see an increase in frequency of urination during the day and also at night. So their sleep is also interrupted. So they're not feeling terribly great about themselves. And if they're so particularly, we would see them after treatment because it's better for them to get their treatment out of the way rather than focusing on a full bladder and doing some exercise at the same time. So we will see them afterwards. And of course, then their bladder is desperate to need, so they will find they need to go a number of times. And I think if you are in a commercial gym, that can be quite a barrier. If you haven't quite got full continence at the moment, it's usually just for a period of time. That can be a barrier as well. So that whole thing of not feeling that control in their bladder and bowels can really make them feel, apart from quite miserable in themselves. And I know it's a sweeping generalization and I'm talking to you, but men are not always as good at talking about how they are doing. So again, we try and give them their confidence back because actually they can still lift. There's not, particularly if they're not post-operative, there isn't really a reason to not be challenging them a little bit on lifting. So that gives them that feeling of empowerment, of control back over their bodies. And we just have to make sure we explain to them and, we are happy if you have to rush out to go to the bathroom, rush out and go to the bathroom. It matters. You're not the first. You won't be the last. It doesn't matter at all. But it's giving them that sense of safety that this is not a thing, because so nearly every one of your male colleagues or male sort of patient colleagues that is in here is going to be going through exactly the same thing at some point.
I mean, even not all women are great at talking about the symptoms of menopause and how much they might struggle with it, and every woman at some point is going to go through menopause. So for males who, like say, aren't known for talking the best, to even have access to other people going through the same thing, to even have those conversations, because they might not want to speak about it to someone who just isn't going to understand if they've not had it. So again, I suppose it comes back to that community in those class-based settings, if people can find them. Because does it tend to be that you try and put the same people suffering from the same types of cancers in the same classes, or is it is just a mix of everyone?
Yeah, it's a mix. So when patients are on treatment, if they come to see in my one clinic where I have the gym, then we will try and follow their treatment. So they're not spending their whole day with us. I know we're lovely, but they don't have to spend their whole day with us. So we will try and follow on from that. And then when they finish treatment, if they're still coming in, then that tends to need to fit with whatever else they have going on in their life, if you see what I mean. But we would prioritize patients currently on treatment, because if we can help them build that confidence whilst they're on treatment, then they usually continue with us. So it's a little bit either or, and it can ebb and flow. You can suddenly have a group of 4 men and 1 woman, and then the next day it's 5 women all chatting. So it does ebb and flow on that basis. We would also try, that some people naturally gravitate towards others, so we would always try and work with that if people particularly enjoy training with each other. So we did earlier last year have a group of men who set up their own WhatsApp group called the Naughty Step, and they were coming to the gym, and the Naughty Step is relevant to Monday mornings, coming back in for treatment, trying to get your bladder working as it was on Friday. It doesn't always do what you think it will do, and so they go on the Naughty Step because they miss their timing for their slot, and we have to move people around. But it's because on a weekend they hydrate and drink differently, and then they come to a Monday morning. So, but everything is really good natured, and that was done in a good natured way. And that was such a support group because they supported each other. It would be like, have you been on the Naughty Step this week? And so I feel that is really powerful because it starts to encourage the conversation around something that is happening to all of those who are having their prostate cancer treatment.
I love that. And thinking back to the episode with Michelle again, concerns around bladder, bowel control were a huge barrier for people getting started, particularly with strength training, because of fears of kind of straining to lift a weight and increasing that inter-abdominal pressure might then exacerbate the symptoms. But then equally, some of the research showing that those who lifted heavier again, gradually over a period of time, but were able to get to a point of lifting heavier, had less issues with their bowel and bladder than women who lifted light weights all the time. Is that kind of a similar pattern and is the evidence out there to show that anyone who's suffered with prostate cancer and had surgery, that they're, by building strength, they're less likely to have the same kind of symptoms around bowel and bladder?
Oh, that's really interesting. I have not seen any research on that, and that would be a really interesting piece of research, because the reason I know Michelle is that when I'm not doing exercise, I'm a pelvic floor physio, so I do a fair amount of that, and I haven't seen that. Would be a brilliant study. I wonder. I will check to see if that's been done anywhere. But I think what we know is, from a pelvic floor perspective, after the pelvic floor exercises, we know that strength training is helpful. And, from a legs being strong, your adductors being strong, that's all going to feed into strength and lift. And then control of the abdominal area and your transverse abdominals will feed into enabling you to leak less. We just need to pull it all together. So I can't see why that wouldn't also be true. And I do feel that, and I like lifting. That's kind of and that's probably why I'm in the right job. I like pushing and seeing not how heavy stupidly, but how heavy I can maintain as I age. So I hope I instill some of that passion in my patients when they're having to listen to me week after week. But I think, they can do, most of them ultimately can do more than they think they can. And you must see that an awful lot.
Mm-hmm. I mean, it was going to be one of my next questions. Is we've talked about the positive effects of strength training in cancer patients, from the cellular level to some of the other sort of just naturally building strength and preventing things and inflammation and those sort of things. I'd love you to say a bit more about that psychological confidence that comes with strength training, and is there anything specific to cancer patients that you've seen that, or any sort of case studies in mind, that you've seen real changes in someone's psychology from having come in with their new diagnosis or recently after surgery?
I mean, I think I should have taken a picture of the wall at the clinic, because the thank you cards of people who just say, you have changed my life now. And for me, it's that locus of control, giving them that locus of control back, really showing them that they're not broken. They're not broken. They've had an illness, and for so many of them, they will go through and past that illness and live a long and illustrious life. So just giving them that feeling of control and back in their own power again, that they can do all of these things. So, when I'm looking at goals, we often talk about, and I'll say, don't you want to be able to pick up your grandchildren? Don't you be able to want to put your luggage in the overhead locker when you're going away on holiday? It's all of those, finding those things that they want to still be able to do. So they do leave with that sense of confidence, standing taller. I think a cancer diagnosis increases our ability just to be retracted. And why would it not, right? But if we can be standing tall, then their breathing helps, and all of that, their breathing returns, everything gets better, and they feel that confidence in their ability to be strong. And I do think it's worth noting. So Professor Rob Newton, who has been instrumental, he's in Australia, but instrumental in exercise oncology. He's a physiologist, and he started the research when his father had prostate cancer, and his father was a little bit more elderly, and his father's advice from his consultant was, just rest, don't do anything. And Rob, as an exercise physiologist, is like, we must be able to do something. And I think had some success, but he would say that, what happened was that his father's general metabolic decline of, potential for not moving, age changes, potentially diabetes, cardiovascular changes, became a huge issue in what he could and couldn't do. So it really is about showing these people they're not broken, and not only can they help push back on their recurrence of cancer risk, but they can actually push back on all of those other aging and metabolic things that are going to happen naturally, because that's what is part of aging. So I feel we have a great opportunity with these people, because they have to listen to us for 12 weeks, really droning on, but in a positive way about how, but the patients are then their own advocates. You'll see people come in and say, I am now doing this, and I'm going back to skiing, and I'm going back to diving and I'm going back to my holiday that I was hoping to do in Australia with my family. So that's when I said to you that I have the best job, because when patients feel that sense of achievement, it is such a lovely thing to see.
It just made me think, is there any evidence, given that someone, or at least from what you've seen, someone who's got a cancer diagnosis almost immediately stops exercise, and that's a vast majority of who you see. Is there any kind of evidence to show that following a cancer diagnosis, there's an increased incidence of other sort of metabolic diseases or things along dementia, diabetes, heart disease, and all those side of things, potentially because of not doing the exercise, not even from a cellular level?
The honest answer is I have not, that I've seen, other than anecdotally, I have had a number of patients who are suddenly pre-diabetic. Now, again, exercise is going to help with that, but I don't have that as a study. But they will say, "Oh, Sarah, apparently I'm pre-diabetic. What am I going to do?" And they're dealing with managing their cancer, so they tend not to have the diabetes necessarily addressed. But I'll say, well, there's a lot we can do. There's a lot we can do with exercise and nutrition around this to see if we can avoid you getting to that point. So I feel it's that. I think we're still lacking in a lot of evidence, if I'm honest. I know I'm confident and comfortable with the evidence we have of how we mitigate side effects and help manage some of the sort of the tumor signaling. But I think in terms of some of the other information, I think it's a lot true in a lot of exercise areas. We don't quite have the evidence to give to people. And as much evidence we can have, anywhere we can find a hook to really help them go, I'm going to hang my coat on that hook and that's why I'm going to do it, is fantastic, right? But I think we're lacking in some of that.
I mean, it would make sense that someone who's not exercising has a risk of that. So like you say, to be able to feel like you've made an impact over the 12 weeks to steer someone back in the direction of avoiding any other kind of age-related condition is brilliant. You've mentioned a couple of times there about sort of the word nutrition, and I realise, again, like me, a physiotherapist, and not wanting to go too far out scope of practice, but in terms of the nutrition side of things, is there any common mistakes, or is there someone going, say, through chemo, tend to have less of an appetite and then eat less? And then is there anything along those lines, and anything you can say to that in terms of strategies to complement the strength training?
Yeah, I mean, I think as you say, it's probably like for both of us, we have more knowledge than perhaps the average layperson, but it's not my area of expertise. We're quite strict on people having had something to eat and have hydrated before they come to exercise, which is a challenge sometimes because there are some articles talking about fasting before chemo. And again, consultants seem to be quite unsure, there doesn't seem to be any consensus around that. So I think we're still learning a lot about nutrition. I still feel I had a patient who was told, so she is admittedly, she's head and neck. So at some point, food doesn't taste great. And from a treatment perspective, we want to do everything we can to help them maintain their weight during treatment. And she was told, I don't know who this was, it's nobody I directly work with, that, have whatever you want, go and have a McDonald's because you need the fat. And another one said, well, you can eat as many cakes as you want. And all I would say is that absolutely, if you want a cake, have a cake. If you want the odd McDonald's, have the odd McDonald's. But from a nutritional perspective, we still need to be eating those healthy foods that can really help make you feel supported and give you energy. So for some of our prostate patients, we have to be mindful of fiber because we want a regular bowel movement. So they will have had that conversation. For our patients who need to maintain their weight, we sometimes support them with other medication, Essure, or just ask them to look at really good quality protein to supplement a little. But I want them to stay hydrated, and I want them to, of course, eat what they like, but just have a little bit of mindfulness in that, because if they are taking all of those foods that have less value nutritionally from an energetic perspective, it really isn't helping how they are feeling. And actually, it's something that on a personal basis, we are looking to see if we can do a course on this so that we can better advise, because I do find it's an area, even more than exercise, that patients will have done their own Googling And then they'll talk to another patient about what they've Googled. And that's not always backed up by evidence. So I'm going to send them back to their oncologist for an opinion and back to the dietitian for an opinion. So I want them to eat as well as they can and eat something they like as a treat, but just consider that their body is having to manage all of this treatment and it needs that fuel to do that.
So, is there any specific, any other specific cancers that someone might have that they need to take any considerations for when planning a program?
So we do see brain cancer patients, and with those patients, we are going to look at what their ability is and if there's any changes to ability to mobilize, for example. So it is about finding out and meeting the person exactly where they are. But I have patients who are being treated for brain cancer who will come into the gym. I'll have patients who perhaps have poor mobility and perhaps one of the more common, for want of a better word, cancers. So it's still their mobility that I'm looking at as well as their cancer. But head and neck can be a challenging, as any of the gastric cancers, because quite often patients will need to have a feeding tube inserted at some point to help them maintain their weight. So then it's considering the movements that we are looking at. So we don't want to compress, for example, the abdominal area at that point. So I would be having them in a more upright position for certain exercises that they were doing. I would not have them, not that we do a lot of it, doing abdominal crunches or anything like that. We'll have rectal or gynae cancer patients, so for whom at certain stages of their treatment, being seated is a challenge. So we might help them try and find a slightly comfortable position, but they can still continue with the basic premise is the same, but it would be, what can we be working on now? So, for example, if they have a feeding tube, I would still get them to do the basic movements. I'm not going to look at any big pulling. I might look at where I am with a row mechanism, for example, and what that might be doing stomach wise. We know that some of our patients, which we haven't really talked about, some of our breast cancer patients are at risk of lymphedema, although I've had a couple of prostate patients who've had nodes who are at risk of lymphedema. And that is a challenge because I feel we don't know enough about that yet. And we then do have to manage the titration of how heavy they lift and how close things are to their body, because that seems to help. But of course, we want to move the lymph that they have remaining around. So the less common ones, very often those patients are really keen to exercise. I think it's because I assume it's partly because they don't fit into the clear categories. So from going and Googling prostate cancer, there are prostate cancer. There are some amazing organizations out there. Breast cancer has so many as well. But I think for things like brain cancer, there is not as much support. There's not as much out there. So I feel quite generally, they want to come to exercise and they'll want us to wrap our arms around them to help them.
How about if anyone's got to stage of any bony mets or bone cancers? Clearly that's a difficult one. Is there any, I know it's pretty individual to the patient, but considerations that you take there?
Yeah, and so that again is about communication with the consultant. So we would, I think it probably, if I'm honest, still makes most of us just go like, there's a pause when you know that, but we will still work with these patients. So we really need to know where their bony mets are. And sometimes I find that's my biggest challenge, is because the patient might not necessarily know or might not be able to articulate that. And I really want to know where that bony met is. I want to know because I'm thinking about spinal cord compression, any changes to that. And we will work with what we have and where we can. So I had a poor lady who was actually told by her consultant to be really, really careful because your spine could collapse at any moment, which is just so unhelpful because 6 weeks before she didn't know she had cancer, right? So then it's exactly as you were saying earlier, it's going back to their functional things that they do. So I said, well, you're sat in a chair with me at the moment, and do you have stairs at home? And she said, yes. So I said, so now you're going up and down stairs? Yes. Okay. And you're getting on and off your chair? Yes. And you're getting in and out of your bed? Yes. I said, okay, so let's just work around that at the moment. So I'm going to give her a wall push-up. I'm not going to get her to do 25 squats, but we are going to do 2 or 3 sit to stand so I think it's hard. And I think very often, because if you're going into a commercial gym, no one's going to touch you with that. They're going to go, we can't. But we definitely, as a group, I would reach out to my colleagues and we will make sure that we are, it will make sure that we are not missing anything. We'll know exactly where it is. And then we will work with what we can. And very often, again, for that patient, just that little bit of control back. What we're looking at is consideration of where their pain might be, consideration if they're having radiotherapy to deal with a MET, that can often help reduce pain, which is really helpful. They'll then be rescanned. So we have to keep really in depth of where they are with their treatment so that we know we are still treating them safely. But it is a challenge. But again, they will get benefit from it. Just that little bit of, I can still do this back.
And we've talked a lot about the benefits of strength training in the management once we've had the diagnosis and treatment going forwards. What about preventative? Is there the evidence to support that the exercise, but particularly increased muscle strength, or at least a process of regularly doing muscle strengthening, reduces the incidence of cancers or any specific cancers?
I think our evidence on that is other lifestyle factors at the moment, smoking, alcohol, nutrition, certain nutrition things. What I would say anecdotally is that those people who were, I would say, pretty well trained, who'd had a regular exercise regime, do better during treatment. So that has an impact. Seem to do better during treatment and come out the end of treatment more easily than others. And I think some of these, it's really hard to research, isn't it? I think we will get to that. I think a lot of the research has been very much focused on, do we know that exercise is safe? What exercise is the best exercise for the side effects, but also to manage the tumour, to maybe reduce the tumour and improve longevity? And I guess the next stage of research has to be, so if you're doing all of this weight training, is that going to reduce your risk of cancer? Or is it that the fact that you're doing a load of strength training means that your overall lifestyle factors, you're a reasonable weight, you have your mobility, your nutrition is probably pretty dialed in, you have a drink, but you're not over imbibing. It's all of that. You're probably not a smoker if you're going to the gym. I would expect, whether we can separate out strength training as the only, there's so many other factors, but we know that people who are exercisers tend to be healthier generally compared to the more sedentary lifestyle.
So we're kind of coming up to the hour mark. So before we kind of come on to where people can find you, I just wanted to just ask another, because we've spoken about a few of the misconceptions that there might be around, say, lifting after surgery and the fact that people want to give up exercise rather than start it through that kind of shock and overwhelm. Are there any other kind of misconceptions that you hear from patients or you hear in the media that you want to kind of take the chance to see if you can change people's minds on?
Oh, that's an interesting one. Let me think on that for a minute. I think the fact that, so we're quite careful to say, what is your new normal going to be? Not everybody will get back to where they were before. And it's about helping them find their new normal. And there will be a new normal. One misconception, not so much about strength training, but just that I would like to share, because we'll all know somebody, right? Is that when the active treatment is finished, so whether it's your 6 weeks of radiotherapy for your prostate cancer, your 5 sessions of radiotherapy for your breast cancer, it's not quite finished. And that person might be looking super well. They might be feeling very fatigued though, but they might be looking super well. And it would be to carry on checking in with your loved ones, with your friends. And you can say they look well, but ask them how they really are, because they are still working through that process. They are still going to have more tests and more scans. And so I think a little bit, not the misconception that it's gone, because it very often has, but they are still dealing with those hospital appointments and that nervousness and fear that A, it might come back, or B, has it completely gone? I have a patient this week who's going for her next mammogram, and the results will be given to her on her 1-year anniversary of her diagnosis. So that's quite a thing. I am as sure as I can be that she is absolutely fine, but she's still suffering from that scan anxiety, which is a real thing. So it would just be to just be mindful that your friends, your family, they finish their active treatment, but there's still a lot going on, and to carry on reaching out to them.
You've mentioned that obviously you work privately, and that's kind of an option for some people who might be listening if they're in your kind of locality. So I'll let you kind of mention that first, and then is there, if someone is listening, they've not had the services offered to them under the NHS at the moment, or they don't seem to be able to get there. If they want to try and find someone similar to yourself, do they simply search oncology physio, or what are the kind of the best things they can search for, or what they should look out for if they're trying to find a physio to kind of help them with it?
Yes, there's lots there. So I'm part of my job is I work for a company called Genesis Care. We are only cancer radiotherapy and immunotherapy, so we are very fortunate in that basis. I work privately, so there will be physios, and rather than oncology, they probably want to be searching for cancer rehab physios or cancer rehab trainers, because there is a level 4 CAM rehab course that certainly all of our exercise oncology PTs have done, and there'll be people at other gyms who have done that. The NHS is absolutely trying. I work with the NHS once a month to see cancer patients. It doesn't ever feel like enough. I feel I can't get through enough patients there. But they can search for cancer rehab physio, cancer rehab PT, and then some of the charities. So Macmillan, prostate cancer. In breast cancer, we tend to have more Future Dreams. There are some really where they do a lot of online exercise. Get Me Back. There are lots of those to search for. So search for online cancer rehab classes, and there will be a lot. And those will be with people who are qualified and understand what stage you're at. I work for we partner with a lovely charity called Penny Bron, and the relevance of Penny Bron, not only do they have a lovely centre in Bristol that is the most relaxing place to go to ever, but they deal with all sorts of cancers, whereas a lot of the charities deal with a specific cancer, but they deal with all cancer types and can offer a lot of support on just little movements, snacks and things. It doesn't have to be a full session. There's a group of physios who will be trained with Pink and Steel, who are actually a New Zealand organisation. And in New Zealand and Australia, that's a purely charity-based funded. Here, we don't necessarily have that funding, but those physios will have done Pink being the breast cancer, Steel being the prostate cancer. And that's a lot around next steps about taking people through their active treatment and then helping them go on to what is next with that. So there are a lot of brilliant charities out there. From a menopause perspective, I would just like to Menopause and Cancer, run by Danny Binnington, who is a breast cancer survivor. There's a lot online. There are some really great podcasts on what people can and can't do in terms of helping manage some of those side effects. So we do have some much better resources than we had 5 years ago, definitely. I was going to say that might be easier said, yeah. Yeah. So if they're personal trainers, have they done the cancer rehab level 4 qualification? Because I think once people have come through it and they're 3, 4, 6 months afterwards, they can get back to fairly normal, in inverted commas, training. But having somebody who knows what you've been through can be really, really helpful and supportive on that, I think.
Brilliant. Is there anything else that you feel that we've missed that you would kind of wanted to talk about, or do you think we've covered everything?
No, I think it's just the message that obviously not all of our patients are we talk about never too old to live. Not all of our patients are elderly, but obviously a larger proportion will be coming towards that. And at a point where perhaps if they haven't started strength training, they have the cancer diagnosis makes them think, gosh, now is just not the time to bother. And it would just be to say it can bring so much more to your life to start doing that, doing it safely, doing it effectively. I love the Arthur Ashe quote, which is, start where you are with what you have, do what you can, because of course any movement is better than no movement. But if you can then incorporate a bit of strength training, there are so many benefits from the cancer diagnosis, but for their life in general, that just explore it. Find somebody who knows what they're doing and just explore it from there.
Do you see the opposite of people who have done a lot of strength training in the past who then stopped and then struggle because they can't quite do it at the level they were doing it at before, and that disheartens them, and the temptation is to then not do it.
Yeah, pace. Yes. Well, don't you think? I mean, I think pacing and compliance are the holy grail of physios or strength training, right? And I think humans are really bad at pacing. I just think it's a human. I was running a 5K. Yeah, well, it's going to take you a little while to run your 5K. I was lifting, and I would think of it, it's not quite the same, and I'm not oversimplifying it, but if you have an injury or if you've been out for an injury for a period of time, you have to pace back to lifting where you were lifting before. So, no. And there might be a couple of occasions where you won't get back to that. For most people, unless they are a professional athlete, they probably will get back to where they were. And if not, carry on progressing past it. But it is that I always say to my patients, I want you to do it long enough that you are bored and you are thinking, Sarah needs to change this. I'm bored with Sarah. She's told me to stick with it, and then I'm going to change it. But I want them to get bored, because then I feel that physiologically your body is ready to go to the next stage. And I think that's particularly important in a cancer rehab setting. But yeah, pacing, hard, hey?
Mm. Yeah, yeah, definitely the most common thing we see. Yeah. Oh, great. Well, I can't thank you enough for giving up your time to come and talk to us on the podcast. I will say put all the links that we've talked about in the show notes below. And I mean, are you on social media, or is there anywhere people can follow you
I
if they
am.
wanted to?
I always have to check what my thing is, what my handle is. I'm on Instagram. I'm at Yogi Physio. I am 100% sure. So at Yogi with an I Physio. That's who I be. Yes, Yogi Physio.
Perfect.
Yogi Physio Sarah is what you want to be looking for, and you will find me on there.
Brilliant. And again, I will stick that in the show notes and the comments. Well, brilliant. As I say, thank you for coming on. And if anyone's got any questions, like I say, can either get in hold of you by there, or if anyone wants to send me an email, it's chris@nevertoldtolift.com, and I will pass those on to Sarah. But for now, I'll let you get on with your day. So thank you.
Thank you so much for having me, Chris. Thank you.